Okay. Welcome, everybody. Thank you for spending your lunchtime with us. All right, so we've got 20 minutes for sports medicine. Welcome. My name is Jeff Fedden from Brown University. I've got some panelists here. We'll do a moderated panel discussion. I will let them introduce themselves in just a moment after I give you a brief intro. We have no disclosures, except that we love sports medicine. From an objective standpoint, this is a career-based talk. So we'll basically overview training and careers in sports medicine, and then try and kind of highlight the how and why emergency physicians have had kind of increasing presence and success in sports medicine. So from a background standpoint, routes of entry into the specialty, emergency medicine, of course, family medicine, internal medicine, pediatrics, and PM&R. So 5 routes of entry into primary care sports medicine. Emergency medicine, obviously, you get your board certification. And then beyond that, it's a minimum 12 months of fellowship. Most programs are 1 year, maybe a couple programs that are 2 years. And then an accredited fellowship program leads you toward a certificate of added qualification that is administered by the Board of Family Medicine in cooperation with ABEM. In terms of fellowships, this is match data. So we're just about 10 programs that are based in emergency medicine out of 234 total programs, so a small fraction. Represents 392 fellowship positions annually. This is 2025 data all the way on the right, and about 488 applicants in 2025, so fairly competitive. Completion of fellowship then puts you into a career in sports medicine, which looks lots of different ways. Non-operative orthopedics, medical care of the athletes, team physician, other administrative roles, and some participate in mass participation medicine as an event physician. The American Medical Society for Sports Medicine is kind of one of our parent organizations, and you can see emergency medicine represents 5%, so we're a small but mighty group. Family medicine is still kind of heavily dominating the sports medicine scene. If you look at ABEM data specifically, so going back to 1993, 348 certificates issued, so we're about 9% of all the subspecialty certificates in EM, and we've had about 150% growth in the past 10 years. In terms of careers, again, we'll get into this with the panel, but academic emergency medicine, other combined practice models. Some practice full-time emergency medicine with team coverage, and then some are full-time in sports medicine, maybe with some per diem emergency medicine. So that brings us to our panel. Got 3 great colleagues here that will share some experiences and insight and wisdom. I'm just going to go ahead and allow them to introduce themselves briefly, their main roles in both emergency medicine and in sports medicine. Start with John.
Is this working? Yeah, try this one. Thanks, Ben. Okay, hey guys, my name's John Keel. I'm EM Sports. I did residency in Buffalo. I did fellowship at Kentucky. I was at UF Jacksonville for 5 years, and then for almost 2 years, I've been at USF building up sports medicine there, where I practice a mix of both emergency medicine and sports medicine.
Hi, everyone. So heartened to see everyone in the room. Yeah, just in our audience, maybe could you just go show of hands of who's a resident, medical student resident, all right, and attendings. Yeah, and who's interested in sports medicine as a building something up. Okay, kind of the minority, awesome. Yeah, so I do an academic practice as well. I did my emergency medicine residency at NYU Bellevue, and then a 1-year emergency medicine-based sports medicine fellowship at North Shore. And I'm now 50-50 split, so 50% of my time is emergency medicine, 50% of my time is PM&R, also under Mount Sinai. And this is in concert with our sports medicine fellowship. So one of the ACG mirrors, we have 4 fellows. 3 of them are PM&R, and one of them is emergency medicine, and one of the assistant fellowship directors there.
Great. Hi, everybody. My name is Ven. I did an emergency medicine residency at the University of Connecticut. I went and did a sports medicine fellowship at the Hospital for Special Surgery in Weill Cornell in New York City, and then came back to UConn. At UConn, I do a mix of emergency medicine and sports medicine. I do 20% orthopedics and 80% emergency medicine. Had the opportunity to work with some cool teams. When I was a fellow, I was an assistant physician for the New York Giants and the New York Mets, and then now I'm one of the physicians for the Westchester Knicks, the G League affiliate of the New York Knicks.
So I can assure you that both Amy and John are also doing exciting things in sports medicine. And as a native Philadelphian, it was difficult for me to put those pictures of Venn up there at MetLife Stadium. But the only thing that allowed me to do that was that the Eagles won the Super Bowl. Okay. So we're just going to launch into a panel discussion as outlined here. I'll pose some questions, give you guys an opportunity for a brief answer, and we'll go from there. So recognizing that there would be a lot of students and residents in the room, we'll start here in terms of exploring interest and thinking about fellowship applications. So those that are either thinking about sports medicine or just more certain about pursuing a fellowship, what's the best way for one to seek out opportunities, experiences, recognizing that this may be different at an institution that does or does not have a sports medicine fellowship associated. And then similarly, what type of experiences would one look for in order to make themselves a competitive applicant? And Ben, we can start with you.
Great. Yeah. I mean, I think that exploring an interest in sports medicine can certainly start during residency. You don't need to necessarily have a faculty member that's trained in sports medicine. A lot of local organizations are eager to have emergency medicine residents and attendings and physicians around for sideline coverage and event coverage. And so that's an easy way to get involved, is just to volunteer with local organizations, especially high schools. Certainly reach out to their athletic directors and see whether or not that's something that you have an interest in. And then, as Dr. Faden alluded to, there's been a growth with emergency physicians within sports medicine, but most hospital systems do have primary care sports medicine providers that you can reach out to and get some experience with. Go see what clinics like, see if that's something that you're interested in, because those are the sort of the two arms of sports medicine is clinic-based medicine and sideline and event coverage. And so I would certainly suggest that if it is something that you're interested in, to get exposure to both of those realms and see whether or not it's what you want to pursue.
Yeah, I can add to that. So I think when building up a fellowship application, there are a couple different buckets that you have to fit. And at least there's the sideline event medicine component, which I think everybody knows intuitively. This is already our skill set. There's a scholarly component, which we can talk about. And then the third one is longitudinal. So I think all of us can talk about, I'm tied into like 4 different professional leagues, and everyone thinks that's so exhilarating. But when it comes to the EM candidate, the skills that we lack is actually that longitudinal component. What happens when you see that same patient again in the training room setting? What happens when it's under-resourced? So it's maybe you, a butterfly, and then you have coaches, parents, the students once you get back into game. So you have just your physical exam skills. And so actually what I would emphasize is try to tie into something longitudinally, because that's the thing that you guys will lack in terms of your fellowship application. And then number 2, yes, I think there is sometimes like a dearth of mentors. And so something that I really encourage is actually private offices. These guys love to have trainees. It's not crowded with like the 10 different specialties that want to rotate through with us. And they're not under strict regulation, right? They kind of do the Wild West because they don't have the giant red tape that some of our academic institutions fall under. So they're doing very sexy things. So try to tie into that in your community.
I'm just going to add one thing, which is I don't want to shout out for the competitor, which is ASAP, but they have a sports med section that assigns mentors to interested residents. So if there's anybody in this room that doesn't have a mentor, right, this is a 20-minute conversation, but a mentor can help you over the next couple of years to be a good applicant. Reach out through ASAP or any of us directly, and we can make sure you find a mentor if you don't have one. That's probably the most important thing I would say.
Thanks, guys. So we'll kind of stay on the theme of trainees and now looking at fellowship programs. So I mentioned earlier that there are only about 10 EM-based fellowship programs around the country, and that doesn't mean that there aren't many, many dozens of programs and spots that are open to EM-trained applicants. But thinking about fellowship programs, evaluating fellowship programs, if you get to that stage, what would you guys say are the kind of 1 to 2 most important factors in identifying a program that might be a good fit?
I guess I'll start. Well, first off, I will say you said there was 10 EM-based programs.
10.
We're going to make that 11.
Going on 10.
We're going to make that 11 at USF pretty soon, guys. I think the most important thing is them either having matched an EM applicant or having a good plan for what you're going to do as an ER physician when you match. So just to give you an example, and these guys may have different experiences, but I went to Kentucky who had never matched an EM applicant, and initially they were like, we're going to put you in an urgent care once a week. And I was like, that's not going to cut it. I don't even think that would work for the GME rules, but I also was just like, absolutely not. And so then the fellowship director called me back a couple of weeks later. He said, hey, I talked to the program director for EM. You'll just function as a PGY4 in the ED for that year. Not necessarily ideal. I'd rather function as an attending. Wasn't a huge issue though, ultimately. The attendings basically just left me alone and I did what I wanted to do. So I think for me, the most important thing, if you're matching at a non-EM fellowship, which is highly likely, right? There's only 10 programs, is that you know what their plan is for you. And that is something that we're working on too. Actually, Ben can speak to that.
So the original question was which to choose from. Yeah, I think part of it too is you have to decide what your career path might be. And so sometimes the fork is, do you want to do event medicine sideline coverage, or do you want to be a longitudinal team physician? So I think one of the more interesting things I do is I travel with the NBA year-round, both domestic and international. And so that branch kind of covers the skills that we do very well, which is how do you recreate like the American standard of medicine and healthcare for most elite population in the middle of nowhere where they're trying to expand the market for basketball. And, do you have deep pocketed resources? Yes, but are you very much limited by the local resources that are available? That what I just described is like a very much an emergency medicine skill set. What do you have when you have like, you're traveling with a bunch of 100 youth, like going to be drafted in, and so now it's a pediatric population, and some of them have diabetes type 1. How do you dose their insulin in the middle of the match? Sometimes a bronchospasm, change in environment. What are you doing with moderate persistent asthma medications? So that's a whole nother skill set I don't carry. So if you think about what is the skills you might lack and what do you want to carry with you in the future, you might then actually want to think about family medicine driven internal medicine or pediatrics based fellowship programs, which conveniently does represent the majority of the programs that do exist. Probably we're the lesser preferred applicant in that regard, but they do carry a skill set that we don't have that you might carry with you into the future.
Just to expand on that, so I did a pediatrics-based fellowship program. I was the first emergency medicine trained fellow. I had a similar experience to Dr. Keel. I worked as a PGY4 in the emergency department, just a few shifts a month, but that was enough for me to feel like I could keep my skills up. There are multiple different fellowship maps that are housed on various emergency medicine organizations telling you about fellowship programs and whether or not they are hospitable to emergency medicine residents. So we're going through and surveying all the programs directly to figure out which ones can accept emergency medicine, have accepted emergency medicine, and what they've done with their emergency medicine fellows in the past to make things a little bit easier on the residents that are coming through to know, which places they should be more interested in. I would say the only other thing between fellowship programs is similar when you go through residencies and try to figure out sort of what your procedural burden will be and how much experience you'll get at different levels of training. The same holds true for sports medicine, right? And so, while we all have great ultrasound training, there are some procedures that are novel during your fellowship, and so you want to be able to get exposure to those types of procedures, and then also different types of injections. Like many sports medicine practices do biologics, and in addition to cortisone and some other sort of tenotomy-based procedures. And so I think there's another realm of procedural training that you get exposed to during fellowship, and so that's another thing that can help differentiate between programs.
Great, thanks, guys. So I want to just shift to clinical practice. So you all are obviously successful in academic practice, combining emergency medicine and sports medicine. That's only a small subset of what our larger group does in terms of academic practice. So if you think about sports medicine practice specifically, what do you think have been your keys to success caring for athletes at higher levels, and why do you think emergency physicians are well positioned generally for success in the field of sports medicine?
Yeah, I mean, I think a lot of it just boils down to adaptability. I mean, that's what we do best. As Dr. Kim alluded to, there's going to be some chronic disease management. That was probably the biggest learning curve for all of us during fellowship. But that sideline coverage is bread and butter emergency medicine. I mean, a lot of that time is urgent care in the training room, right? Taking care of acute illnesses. And so I think we are uniquely qualified to be able to do that, and I think the sports medicine community is finally realizing that and is becoming more accepting of emergency physicians, which is why you've seen the 150% rise in training.
So I guess I'll interpret this question to talk about literal clinic and that outpatient setup and how you recreate that. I think for me, I always describe there's my emergency medicine Zoom meetings, my PM&R-based Zoom meetings, and then there's the Zoom meetings of those kinds of operations that are in between. So part of our clinical practice is interesting because we created things that are new. So non-operative fracture management, for example, so much of MSK, as we know, is non-operative or non-emergently surgically operative. I see a patient population that's very underinsured and underrepresented. We see a lot of continuity from the emergency department. I'll have Our program directors, residents all rotate through. So it becomes a very interesting space of that in-between spaces, which is what people need. You now access an ambulatory space that's very foreign to both the outpatient and to the ED world. And so being liaison there is a very unique skill that you guys will create where you come in. And I think the second thing I want to comment on, too, is what you mentioned, which is adaptability. We're very procedurally heavy. And so I noticed that even in a interdisciplinary outpatient space, be it the PM&R guys, outpatient family medicine, et cetera, I do think emergency medicine tends to incorporate skills very readily. We are the first people to take out the ultrasound, bring out the needle, stab and look for things that other people might not be as renegade to. I will have to put in a plug for our own fellowship, although I want to evade it, which is we are PM&R based, so we do interventional spine. And so the ED resident comes in being like, what's about fluoroscopy and how do you rip down an MRI of a cervical space? Very new. And then I would say by August, they are the strongest fellow year after year for the last 7 years that we've matched. Just because very procedurally inclined, 2-dimensional fluoroscopy is very different from 3-dimensional ultrasound. And so in the future, that becomes a very marketable skill and something that, delineation of privileges, DOPs, ED residents who are graduating to fellowship are very ready to sign that off. Chairs are happy to sign that off, big RVU generating models. And so if you think about what you're willing to incorporate it in, those skills are something that you'll carry with you forever in building your clinical practice.
Good.
You want to? Okay. I'm going to interpret the question a little differently, I think, which is just to talk about what clinical splits can look like for EM, SM, right? So there are some emergency medicine sports fellowship trained folks who do 100% sports, and there are some that do 100% emergency medicine. Most people are probably somewhere in between. Those people in between are maybe in private practice in a mixed model. They're 100% university-based, like Ben, are you 100% UConn? Right. That's, I think, the best model because you can switch between departments fairly seamlessly. That's what it was like when I was at UF in Jacksonville, right? So basically, my EM chair loaned me to orthopedic surgery for a day a week, and there was opportunity to scale that up, had I stayed and decided to do that, right? At USF, it's a little bit different. We have a marriage, an awkward marriage to Tampa General Hospital, a good marriage, but it's sort of evolving in real time. And so historically, sports medicine there has been housed in family medicine, and EM has not had a sort of presence in sports medicine. So when I joined USF, my job there is essentially to build up that division within our department in collaboration with USF Family Medicine, Sports Medicine. And so my practice is evolving. We're like right now, just to give you guys an example, I do about half emergency medicine and half sports. My sports is 1 day of clinic on Fridays through USF Family Medicine, who have graciously loaned us some clinic space. And then we also cover USF Student Health Urgent Care, where we've built up a sports medicine practice. And then on top of that, perhaps most importantly, is we're building out our own sports medicine orthopedics practice through Tampa General Hospital within the Department of Emergency Medicine. So there's a lot of ways to get to what you want. And that's not even talking about team coverage, but just the clinical footprint. Okay.
Thanks, John. So we're just about at time. So in maybe each 30 or 45 seconds or less, we had a few more things to cover. So you can speak to any of these that you feel comfortable with. It's not, those of us that have done it, it's not an easy path necessarily to combine practices to develop your sports medicine practice. So any specific challenges that you've encountered that have already not been mentioned? Are there opportunities in sports medicine for those that are in clinical EM practice that may want to participate in sports medicine but do not have fellowship or do not wish to pursue fellowship training? And then where do you see the future of the subspecialty going in coming years? It's a lot, so you can kind of pick what you'd like to answer, and we'll wrap it up.
Okay, I'm just going to elaborate on my role at USF. My chair's in the room, so I just want to make him happy, okay? Yeah, great, perfect. So again, sort of elaborating on one of the things that I had to do is figure out where are all these patients in Tampa going, right? Most of Tampa is run by a couple of private orthopedic groups, but I pulled all the data from all the outpatient clinics. I pulled all of the data from all of the outpatient urgent cares and the emergency department. I said, where are the MSK ICD-10 codes going? And the answer essentially was they were all leaving USF and Tampa General, right? So then I present that data in a sort of interpretable way to my chair, to hospital leadership to say, okay, there's a need. And so we're turning that into a need. That's one way I have just demonstrated value to both my department and the hospital. We're going to build out an entire clinic based on that information. Another thing that I did when I got to USF was we basically started our own conference that we do every year in July. Right now we're calling it a SMART conference, which is kind of playing off what they do at AMSSM, and it's sort of EM heavy, but it's essentially trying to bring together all of sports medicine in Tampa, including family medicine, some of our competitors, some of the private physical therapy groups, athletic trainers, et cetera, under one roof. So we're all sort of on the same page. We all know each other. We can network. And then ultimately, we're building up the USF Tampa General brand by doing that. So those are two things that I think are opportunities at anywhere. You just have to go out and find them.
I guess my parting words would be to reach out. If I think about when I was applying for fellowship, one of the first people I ever spoke with was Jeff Faden, who graciously mentored me through. John and I met because he and I were doing a MSK workshop, like a national conference. And then I met Ven in New York Giants room. It was Giants versus Jets. And so as you can imagine, that world is very, very small. Yeah, and there's continuity there. And number two, I would say that actually represents a good model of our year. Sports medicine is very predictable. Come July, you're starting with pre-participation exams, right? Lots of different schools. Fall sports happens. I have football, basketball, tennis, USA fencing. Just like that, December rolls into May when it's academic conferences, right? SAEM, ASEP in October, then April, AMSSM. I have a bunch of PM&R conferences. And just like that year cascades out year after year, it's very predictable. So I would say in any of those buckets that I just mentioned, a scholarly activity, longitudinal care, sideline component, those are the three buckets that you need to cover for fellowship. If you tie in with any of us, there is something that is happening all literally year round. So please be sure to reach out and know the names that are involved. Probably like, what, 40 of us, 50 of us that practice both the combined specialty?
That are active, yeah.
Yeah, right?
Ben, take us home.
No, I mean, I think as you guys could probably see over the last 20 minutes, a lot of us have a balance in our careers and our lives from doing fellowship and in the roles that we have now, which I think is certainly priceless. And, by doing fellowship, not that you should do it just to become marketable, but you have a unique skill set that very few people with emergency medicine training will have, and you will be able to find a job. You may not find your ideal job right away. I think all of us have sort of had some evolution in our jobs and to get to the place where we are now. But, going to especially academic places that, to increase residency education in orthopedics and to be able to increase exposure to common musculoskeletal problems, I think is truly worthwhile. And yeah, I don't think any of us regret choosing the career path that we did.
Great, thanks, guys. Appreciate the insight. We've kept you a few minutes late, so thanks everybody for joining us on your lunch break. I'm sure, are willing to stick around for questions. There's some resources here for you. Thanks again for showing up.